So I was supposed to talk about mutational testing and role for decision-making in colorectal cancer. And this, of course, leads to a question of what drugs do we have available right now, and in which cases would you actually test for biomarkers before you treat patients. So you have chemotherapy agents here, older and newer chemotherapy agents, targeted agents, and more recent targeted agent. Another agent hopefully will come to this mix, and then I need to get a different puzzle layout, task 102. Now, some of these agents actually have negative predictive biomarkers to exclude patients, and these are the two drugs, cetuximab, panitumumab. We'll talk about that. Now, it would be nice to have a positive selection marker, which patient should be treated when a certain biomarker is present, and unfortunately, we have not a single positively predictive biomarker for selection of our patients. When we normally talk about biomarker, we talk about targeting, using these biomarkers to distinguish between patients that can benefit from EGF receptor antibodies and VEGF, anti-VEGF therapy. And I want to highlight to you, importantly, the difference between EGF receptor targeted therapies where you hit tumor cells directly, and tumor cells, as you know, are genetically unstable. So they might have, before you treat them, genetic aberration like RAS mutations, which render the treatments that you inflict on these cells inefficient. Now, endothelial cells, which are the target of anti-VEGF therapy, they're provided by the host, they're genetically stable. There is not a single pre-treatment biomarker that we found to characterize patients who should or who should not be treated with anti-VEGF therapy, and the mechanisms of resistance are different. Probably not mutation-based, but probably upregulation of pro-angiogenic pathways over time under the pressure of an anti-VEGF therapy. So mechanisms are very different. We do have biomarkers for anti-EGF receptor therapy. We do not have biomarkers for anti-VEGF therapy. Now let me highlight to you, and I don't have a lot of slides on anti-VEGF therapy, just want to make some educational points. This is the pivotal trial that led to the approval of bevacizumab. You see strong effect on time-related endpoints, weaker effect on response rate. IFL, clearly not the best backbone that we should use, but at that time it was one of the standards of care. When you look at the progression-free survival, please keep in mind these curves separate early, they stay separated, come back together. It is the best parameter to really compare between clinical trials if we look at magnitude of benefit. As you know, is hazard ratio, not necessarily the median, because median is affected by the 1 point of patients on the one curve and the other curve. So a hazard ratio of 0.54 means a 46% reduction of death events. Now, when we interpret clinical trials nowadays, we shoot for overall survival benefit, and now we have trials that move overall survival and shown overall survival of more than 30 months. It's important to see where the survival benefit comes from over time. When you look at 2004 to 2014, most recent data, median progression-free survival capturing first-line therapy is stable. We're about 10 months. This is where we are right now, and we have not made a lot of advances in first-line therapy. What we have seen, though, is that overall survival has increased to now, as I said, 30 months. In 2004, 50% of a patient's life was covered by first-line treatment. In 2014, 15, it's 1/3. So the impact on second and third and whatever lines of therapy you move beyond first line is more profound, and this highlights the availability of all these agents. I want to move into biomarkers. I want to familiarize you with an Italian trial, the so-called TRIBE trial, a kind of ambitious trial, FOLFOXIRI bevacizumab versus FOLFIRI bevacizumab, induction maintenance therapy, so not patients were not treated to progression with FOLFOXIRI bevacizumab. Progression-free survival endpoint here, nicely achieved. 12 months is actually pretty long, but you're really using a triplet, which can be quite aggressive on patients. You see a higher response rate as expected. You add oxaliplatin into this FOLFIRI backbone. And overall survival trends statistically towards statistical significance within a stratified hazard ratio of 0.79, a p-value of 0.54. And it's really a difference, if you like, medians of about 5 months, which is not trivial. Now, this looks good, but who should receive FOLFOXIRI bevacizumab? I use it in patients with BRAF mutant tumors. First, approach that I'd like to show you in terms of a potentially positive selection of patient population for a certain treatment. BRAF mutant tumors, here those are the patient BRAF mutant tumors, which are about 8% of the advanced colorectal cancer setting, and these patients, this is hazard ratio here, had the greatest benefit from a triplet compared to a doublet in combination with bevacizumab. This is not, let's say, the only answer. It's not easy to collect patients with BRAF mutant tumors because they are, as I said, only 8%. But if you have a patient who's not a candidate for clinical trial, you don't have a clinical trial, this is a good treatment. Why is that so important? BRAF mutant tumors have a very poor prognosis, and they are very different than KRAS or RAS mutant tumors. In our bubble diagrams, when we look at RAS and RAF one step below, from each other, it suggests, they're very similar, but they're very different tumor types. RAS and RAF mutant tumors are very different. You see, BRAF mutant tumors in a gene expression profile are very distinct compared to BRAF wild-type tumors. And in this Kaplan-Meier curve of overall survival, you can see after relapse from an adjuvant trial, BRAF mutant tumors have a very poor prognosis. Here, median survival 7.5 months compared to wild-type tumors 25 months. These patients deserve better therapy. FOLFOXIRI-BEV could be one of the treatment options to give aggressive tumors aggressive therapy. See what we did in pancreas cancer. But they also need to be included in clinical trials. And you already heard from John earlier today, BRAF V600E mutations have very different therapeutic consequences in melanoma, where vemurafenib as a BRAF inhibitor has shown a nice response rate, even if it's only transient. But the same mutation, which apparently drives bad biology, has very little activity, and the same agent has very little activity in the same mutation carrying colorectal cancer. So we're not just going to be pathway docs. We still need to embed this whole, the mutations into a tumor entity context. And this is really our challenge right now that we're trying to embrace. Now, we have a clinical trial ongoing in the United States, and I can only encourage you, if you have access to the NCTN program, the SWOG 1406 trial led by Scott Kopp. It's an intergroup endeavor to add cetuximab to vemurafenib to kind of counteract some feedback loops that could be the reason why vemurafenib alone is not active in BRAF mutant colorectal cancer. We need to screen more than 800 patients to get 72 patients randomized. This is the challenge of this new generation of clinical trials. Now, EGFR receptor antibodies are the poster child for the development of predictive biomarkers in colorectal cancer. And we're targeting an antigen on the surface of tumor cells. We're trying to shut down downstream signaling pathways. But when a pathway component downstream is activated, like RAS, mutated, activated, whatever happens upstream, at least in this simplified manner, doesn't matter anymore. We have data from a last-line clinical trial, an Australian-Canadian study, where KRAS exon 2, and I highlight KRAS exon 2 wild-type tumors, really were the only tumors that had benefit. Nowadays, would use an extended RAS analysis, and the data would be even better. But you can see a single-agent cetuximab in a selected patient population, doubling progression-free survival and doubling overall survival. Actually, not a bad benefit here. Now, when you move cetuximab in earlier lines of therapy and you add it to FOLFIRI, you use the CRYSTAL study, for instance, a large trial, 1,200 patients with a progression-free survival endpoint. In the initial readout, the primary endpoint of the paper was actually this one here, non-KRAS adjusted. We didn't have any idea about KRAS even at the time when the study was conducted. KRAS came to our attention in 2008. And as you can see here in this unselected patient population, these curves dance around each other for about 45% of patients. Very miserable efficacy parameter, and the median really doesn't give you the story. Now, whenever you see anything like this here, there's a subgroup effect, and a subgroup of patients cannot benefit. Now we know it's the KRAS-RAS mutation population that cannot benefit. And we eliminate those here. Now you can see the KRAS exon 2 wild-type tumors, the curve split at about 15%. Now this looks a lot better, and the study is actually positive for survival. Remember when I showed you the curve for bevacizumab added to IFL, early separation of curves, and the curves stay separated until patients progress. There's not a single hint of a subgroup effect with anti-VEGF therapy in any trial you can look at, pick any tumor entity, first-line progression-free survival curves always separate early and stay separated. We'll never have a RAS-like biomarker for bevacizumab and other anti-VEGF therapy. Now we move further on to not just KRAS, but RAS, based on the data of the so-called PRIME study, adding panitumumab to FOLFOX. The panitumumab, the Amgen study, is actually much better conducted than the cetuximab studies historically, because the key issue is they had biospecimen for more than 90% of patients, and they were able to go back down and look into their data, for instance, separating out wild type versus mutant KRAS, exon 2. Blue panitumumab is better than yellow without panitumumab. You can see here, this is benefit, this is detriment. Detriment if you don't test for KRAS, and we all have been doing this for quite some time now, and you treat the wrong patient population, might have a detriment. Now the story went further because the PRIME investigators could look at the other RAS mutations, so KRAS exon 3 and 4, NRAS exon 2, 3, 4, and they identified 17% of patients with additional RAS mutation, which your normal KRAS exon 2 test does not cover. And importantly, and this is the New England Journal paper, and I want to highlight the last bottom part here. This is overall survival for the other RAS mutations. And on the right side here, this dot is on the right side in this forest plot, potential detriment. You have a 29% increased risk of dying if you do not eliminate those patients up front. Patient safety. I would say if you don't have a comprehensive RAS test, exon 2, 3, 4 of KRAS and NRAS available right now, use of EGFR receptor antibodies is contraindicated. You need to get this test up and running. There are so many test centers in the country right now, and even NCCN guidelines now eventually support it. Now, one of the highlights, in the last year or so, in terms of our discussion in colorectal cancer, and which leads into some of the biomarker discussion, of course, was the head-to-head comparison between cetuximab and bevacizumab. We had 2 large studies report out in the last year and a half. First that reported out was the FIRE3 study, a German-Austrian study. 600 patients, 590 patients, randomized FOLFIRI, cetuximab, or bevacizumab. Response rate, as investigator assessed response rate as primary endpoint, is a little bit questionable. And actually, when I saw the design of the study, I thought this was stacked for cetuximab, because that's where you see the response and not necessarily in bevacizumab. Questions also, is a response rate endpoint appropriate for phase 3, because the phase 3 really wants to change standard of care or validate standard of care. Again, it's a question, but the study had interesting results, as you probably heard. Surprisingly, primary endpoint was negative, no difference in response rate. Now, subsequently, we've actually seen, when you look at, let's say, evaluable patients, when you do an independent review, as expected, cetuximab does give you a higher response rate, particularly in RAS wild-type refined patient population. Now, progression-free survival was negative, as expected. And again, you can see here in this modern trial, 10 months median progression-free survival. This is very similar to what we've seen historically in almost every single trial in the last 10 years. Now, the surprise came with survival difference, with a curve that splits at about 2 years. And when you look at the outline of the study here, progression-free survival is characterizing first-line therapy effect, and these curves split here when fewer patients are on the study. In fact, when you look at this split, when the split is widest, the split is carried by 13 patients. But we cannot ignore, as a secondary endpoint, there's a hazard ratio of 0.77, and if you like medians, again, a median difference of 2.7 months. Now, how would that turn out if you refine the patient population further? And the investigators were able to kind of do a comprehensive RAS analysis within 2 months and identified another 15% of patients with mutation, all the other RASs. At that time, comprehensive RAS testing was already standard of care in Europe. This hit Europe in June of 2013. So the comprehensive RAS testing was mandatory in Europe in June of 2013. We're about a year and a half behind that. Now, when they did all RAS wild types, so KRAS, NRAS, exon 2, 3, 4, now the curve separated wider. hazard ratio of 0.7, you like median 7.5 months. Now, this, of course, is very surprising. No difference in progression-free survival, difference in overall survival. What are the reasons? Could there be an imbalance in second and third line therapies? Could there be an optimal sequence of events, whatever? And there was not a great answer. So the investigators actually used a construct. They actually said, okay, the depth of response, you probably never heard anything of depth of response before FIRE3, said, you know, if you have, let's say, a treatment that's remarkably more efficacious and pushes the tumor back further, the progression time might be the same from the less effective and more effective therapy, and but there could be a difference in tumor volume, which eventually translates into a difference in overall survival when a critical lethal mass of the cancer is achieved. Now, the problem with that is I really don't believe that, because you know, it's really not like this here, because 10 months here, and actually it's 30 months median survival. So do we really think that the curves, these linear curves, go kind of straight up, you know, unaffected by second and third or whatever lines of therapy you do, and the timeline is a lot wider and longer here, so what really happens is probably something like this. Do we really believe this? I don't think this is true. There's something different going on. And keeping in mind that even if we talk about 10 months first-line PFS, median duration of therapy was about 5 to 6 months, so even shorter than that. We still don't know exactly why that is. So what we really like to have is, we like to have a confirmatory trial that what we observed here is real or not. We need a trial adequately powered for overall survival, larger sample size, and we have this study. It's our own US Intergroup study, 8405, head-to-head Bev versus cetuximab, almost twice as large of a study. FOLFOX and FOLFIRI backbones, you'll see there's not a lot of difference between these backbones, and adequately powered for overall survival. So this is really the proof whether FIRE3 would be right or wrong. Now, there's no difference. There's no difference between cetuximab and bevacizumab in PFS, not expected, not in overall survival. Now, whether you use FOLFOX or FOLFIRI, it really doesn't matter. First-line treatment is really not the carrier for overall survival, which happens, again, 20 months down after first-line therapy. If you use RAS mutation analysis, and eventually after a year we pulled that off, 15% of patients had these RAS mutations that we normally do not characterize. And again, no difference in progression-free survival, no difference in overall survival. Whether you use FOLFOX or FOLFIRI, progression-free survival, you look at FOLFOX or FOLFIRI in overall survival, absolutely no difference. Now, a lot of people said, you know, why are these results so different between 8405 and FIRE3? And I actually believe they are more similar than dissimilar. In 8405, as in FIRE, we see higher response with cetuximab. We see the same progression-free survival. And when you look at the survival data, you know, 3 of these 4 arms have exactly the same outcome. It is just one outlier. It's the FOLFIRI bevacizumab arm in the FIRE3 study, which is inferior compared to the other arms. And I can show you a PowerPoint experiment. You can do a lot of experiments with PowerPoint. This is 8405 FOLFIRI arms here, bevacizumab and cetuximab, virtually identical. And you superimpose FIRE3, you can see the one arm, the cetuximab arm, really projects in between the other curves. And the outlier is really the FOLFIRI bev arm. Keeping in mind that in Germany and a lot of countries in Europe, the duration of anti-VEGF therapy is shorter. There's no financial incentive. Actually, there's a disincentive to continue expensive drugs in most of these countries, whereas here, of course, we, as John said, you know, we make money out of really selling patients drugs. Now, conclusions on these antibodies, you can use cetuximab, panitumumab. You need to have comprehensive RAS testing before you treat patients. As I said, you know, FIRE3 and 8405 are more similar, and you have treatment options. You actually have, if you use antibodies in first-line therapy, you can use in RAS wild-type tumors, chemo EGF receptor antibodies, supportive evidence here from these studies, chemo bevacizumab, you have evidence here. So whatever you pick and choose, it allows us to tailor our therapy according to patients' needs. But what I believe, though, is what you really should do, and this is on my last slides here, it really all starts with molecular testing. And if you have any RAS mutation, these are the majority of patients now, EGF receptor antibodies do not play a role. You might go with your VEGF inhibition up front. If you like antibodies, use VEGF inhibition beyond progression and regorafenib here. If you have all RAS wild type, 40% of patients, now, yeah, you can start with an EGF receptor inhibitor, panitumumab or cetuximab. You go for bevacizumab second line, but you can also use EGF receptor inhibitor as a salvage therapy option. You have data on all these. You have phase 3 data for all these different brackets here. Now, BRAF mutant tumors, they deserve special attention. They should be included in a clinical trial. There are a lot of clinical trials ongoing right now. This could be one of those cancers where you want a triplet combination and use kind of other agents, sequentially. If you don't have access to a clinical trial, there was a recent paper, actually, European Journal of Cancer, about 2 weeks ago, that BRAF mutant tumors do not benefit from cetuximab and panitumumab. The question is still out there because it's a small patient population. Meta-analysis was needed. But be careful, I would not use EGF receptor antibodies as first-line treatment outside of a clinical trial in these patients. Now, I'd like to finish with a slide that Alan Vanuk showed at the plenary session last year at ASCO. This is the meta-analysis that brought us leucovorin. You see the benefit for leucovorin when added to 5-FU. This is what we base our treatment on. It was statistically significant. It was a meta-analysis, and miserable. Now, this is where we are right now, 20 years later, with a survival curve in 84.5. Now, one point I'd like to make in response to John, I don't know whether John is here, when you're too ambitious, John, you're there, okay. I know there was a position paper from ASCO, led by Alberto Sobrero, Lee Ellis, etc. What is the difference we should shoot for in new clinical trials? A hazard ratio 0.7, median difference in overall survival of 4 months was kind of a moderate benefit of trials that we should shoot for. If we had done this, we would have never approved oxaliplatin, irinotecan, bevacizumab, cetuximab, panitumumab, aflibercept, regorafenib. Never. So we would still be here. So we should not underestimate the importance of incremental sequential differences we've made over time, because I like to be on this curve and not on that curve. So that is just my response. Whether this is true for anything future we are doing with better technique and molecular characterization, etc., is something different. Okay. With that, I'll close, and I think we should also reserve questions later for the panel discussion. Thank you very much.